Hello, everybody. Welcome back. So we're on week 2 of Mondays with Moshe since our little summer hiatus, and I see some people are coming back, so it's nice to have you back. I hope that for those of you who are winding down your vacation, looking forward to a new year, new school year. For those of you who are still on vacation, lucky you. So tonight we have the honor of having Chana Mark out from Muncie area, licensed clinical social worker out in Muncie area in private practice. Chana, you also taught, did you teach in a university? Just remind me.
I taught an undergraduate level course in developmental psychology to Beis Yaakov high school seniors.
Okay, developmental psychology. So there it is.
Yeah, for many years. Yeah.
Yeah. So Chana is a psychoanalytic psychotherapist and has been practicing for many years. This is a second career or a third career for you?
Second.
Something like that. Okay. And this is actually part 2 of a series where we are discussing one of the mysteries of psychotherapy, and that is the curative factors of psychotherapy. What actually cures in the process of psychotherapy? For those of you who are joining and are new here and are not aware, I just wanted to let you know that we are doing, I am doing currently a series called Lunch Break, which takes place during your lunch break at 11:30 on Thursdays. And we are really discussing this very point. How does psychotherapy work? What makes it work? What heals the person? How do we reduce the pressure and the anxiety from the therapist having to fix the client's problem and instead engaging in a healing process? So that is something that we began last week on Thursdays. It's Thursdays at 11:30 Eastern time. It's a series right now of 5 Thursdays. For those of you who are interested in signing up, let me know. We do have almost 85 to 90 people who signed up for this. It's a very quick power training. So it's a 30-minute weekly training for 5 weeks where we talk fast and we get the concepts in. We probably won't cover everything, but it's a really good start. Those who joined last week, it was our first week and they really, really enjoyed it. And they're looking forward to the second week, which will be this Thursday, Mirz Hashem. So it's 11:30. And for those of you who are interested in participating in this half-hour power training, please shoot me an email. You can still get the recording from last week, and then you can join live for this week's continuation of this 30-minute power training course. So last time Chana was on, a couple of months ago, we had been discussing, I guess, what I guess we would call the beginnings of how psychopathology begins to develop. I don't know if we even got to that idea, but we were talking about attachment and how babies attach with their mothers and what that actually does for them developmentally, which of course has an indication as to what happens if they don't properly attach and how that affects the child. So how about if we start with you giving somewhat of a overview or a synopsis of what went down in part 1, and then pick up in part 2 so that we continue following the trajectory of how psychotherapy heals people.
All right. We're really focusing on what is it about the therapeutic interaction that's curative, as opposed to the intrapsychic healing or the relief from symptomatology, which could be another focus of healing. This is very specifically designed to answer a wonderful question that Moshe had asked a guest several months ago, and I thought I was riveted by his question. He had asked, what is it about the connection between therapist and patient that's curative? That's so important for us to understand. I'm going to do a little recap here. We're going to be using as our framework the work of Margaret Muller, who studied this was her life's work. She studied the bond between mothers and infants with the express purpose of understanding how the bond enables the baby and child to develop. That is going to be our starting reference, because in fact, we as therapists are taking the role of the therapist mother, in a sense, in being able to provide a nurturing environment, a nurturing emotional environment, so that the patient can feel safe to be and safe to allow him to receive our nurturing, so to speak, and our provision, our nourishment for his mind, to enable him to develop past the points of developmental arrest that are tormenting him. Okay, so with that, I'm going to just do a recap and bring us up to date. Moshe, that's what we're doing, right? Okay. Okay, so we understand that what we're really trying to do for a patient is enable, we said last time that everyone who comes into our office has trouble connecting to the people around him and has trouble connecting to himself. And that inability to think about themselves, even if they want to, is a source of great torment. So what we're doing here is we're enabling them, using the template of our healthy connection to them, to be able to take that and bring it in the service of their, to interject that. Interject means to psychologically take in, yeah? Okay, and to bring that in their ability to relate to other people in a healthy way. Now, what happens here is that once a person is, we've given him room and the ability to be, and to be able to be for himself and by himself, to experience his own reverie, his own thoughts. This gives him the capacity to put to words his own feelings and thoughts, okay? And that enhances his ability to be alone, to be by himself, and ultimately share himself with the people around him. So this is what we're aiming for as therapists. We were talking about, excuse me a moment, give me a second here. Excuse me. We started talking about Mahler's normal autistic phase from birth to 1 month, where a baby is intending to internal stimuli also. And that might, if you think about the parallel to that, you might think of, say, a schizophrenic patient who's only busy with internal process and really does not know yet how to connect properly to outside. But at the end, the important part here is at the end of the normal autistic phase, autistic meaning attending to oneself and one's internal stimuli. At the end of this, the baby achieves homeostasis in that he learns that mother will come. He will not be left to die. And he can, it is the beginning of his building of what Eric Erikson called basic trust. And basic trust. Why? The mother takes care of him. She has a great deal of physical contact with him. She's holding him physically and also emotionally. He cries, she comes. And that holding environment that we provide for our patients is one of the most fundamental aspects of the curative process. And they experience us long before they can verbalize it, even to themselves. We are there holding all of their feelings, holding all of their crazy as they experience it themselves, okay? Holding it all and allowing them to go on being. Try to picture how blissful it is for a baby with a good enough mother who, without being able to identify it, certainly can simply go on being. That is what we want to provide for our patients.
Okay, Chana, can I
Please.
pause? Can we pause for a minute? So
Yes.
when you talk about this, the normal autistic stage,
Normal autistic stage, yeah.
normal
Right.
autistic stage. So you
Mhm.
said that's about the child attending completely to himself.
For the first month of life. It's
Okay.
the first month of life. If you've ever seen a newborn infant, they're busy squirming and gurgling and their eyes are closed a lot. They are tending to internal stimuli, and yet at the same time, learning, neurologically learning that mother cares for them when they need something. They're hungry, they're fed. They need soothing, they get it. They need to be put down to sleep, mommy puts them down to sleep. And this entire environment of their, at the same time, beginning life, being able to attend only to their personal, their needs, and yet and sensations, and yet at the same time having their needs met, their existential needs met, will allay the anxiety that all creatures feel about the fact that if they don't get their needs met, they will die.
Okay. Now you compared that to the schizophrenic.
Well,
Can you tell me a little bit about what you mean by that?
Sure. A little bit. Schizophrenia is, we think of hallucinations, we think of delusional thinking. All of this is very important, and I want to just say, by the way, when you're treating a schizophrenic adult, all hallucinations actually have very deep meaning. What hallucinations are, or what delusional thinking is, are they're certainly very it's called primitive and so on, but it all has meaning, and that is we therapists are there to understand and help the patient put into words what he can only express to himself in these ways, because words, he's not yet up to words expressing feelings. He doesn't have that capacity yet. But what I meant to say is that in the same way that an infant only experiences sensation, certainly has no verbal ability, and only attends to himself internally, and is not able, without the mother's help, not able to connect to other, although the capacity exists and he's born with that capacity. In the same way, a very ill patient cannot from himself, even though he yearns to do so, cannot from himself know how to make those connections to the outside world. And it is we as therapists that hold and help him think, and help him verbalize, and help him understand meanings when that becomes possible, so that he can then be enabled to make the connection to us through interjecting that we connect to him. And over time, it can take years, learn to put things into words, learn to see reality for what it is. And that, of course, has so many components, but that's kind of where you're going. But the idea here is that until an autistic child is very self-absorbed. This is normal autistic, Margaret Mahler called it, because a newborn infant, until he's connected to, is only capable of connecting to his own process in the same way that a schizophrenic person, without our providing connection, can only connect to his own process.
And is there a connection between in other words, what's the reason that the schizophrenic has to be so completely self-absorbed in that way? And what's the reason that the infant has to be, like, I imagine the infant is entering into a whole new sensory experience that's almost overwhelming. And so,
It's exactly what the birth experience is. Yes,
yeah,
precisely that.
you remember that?
I
You
went
can't,
back pretty far.
you
I'll
couldn't
tell you.
possibly remember that. Okay. You say that's how the birth experience. Okay. And
It is.
is there some similarity to the schizophrenic? Is he also so absorbed in in the overwhelmed sensory experience? Is that why that's happening? Is there a connection to the first month of development and the schizophrenic? Or
Well, it's a very, very interesting question. I think that there is a parallel there, but in a sense, but I think the point that I wanted to make is that until the infant experiences maternal connection and care, until the infant experiences that he has needs that can be met by the other, uh, uh, human connection is not possible for him. And in the same way, once a schizophrenic can allow himself to experience that the therapist is not a threat to his existence, that the therapist will allow him to be, that will try to connect to him, he might be able to allow himself to be connected to the way an infant does very naturally allow himself to be connected to. I mean, they're not exactly the same. And this is really the key. The key that I was focusing on here was that anyone who's caught, whether an infant or a schizophrenic, caught and trapped and imprisoned in their own process and not able to relate, needs us, the therapist, to come in there and provide him with nourishing connection that he can learn to count on. In a baby, it happens very naturally. In an adult schizophrenic, it might take a long time.
okay. So let's go back to our holding environment. The mother creates a holding environment for the child, which again, you're describing as having the child feel very safe in the world, feel, I think Erickson called it trust versus mistrust, right? Or in the case of a baby boy, it's trust versus Mr. Trust, right? Sorry, that was a bad one. And so the child begins to feel safe and calm and soothed in the world, and that's the experience, the relationship that the child begins to develop with the world. Is that right?
Well, if we think about holding, I would say that it's a little bit more than feeling merely safe. It's also that your surround provides for you. The physical holding is a metaphor for the surround that we all experience that holds us, our familiar and giving environment, that we have what we need in our immediate surround. That is the experience that enables a baby to not only feel safe, I think it's beyond that, but once he knows that his existential needs are automatically met, he can then let go of the anxiety and the threat, that the existential threat that you see in borderline patients, that you see when you didn't understand them, and now all is lost. All is lost. You abandoned them, you dropped them, it was a rupture, right? So that's a very infantile, early response to a child and a baby that did not have ongoing, consistent care that would allow a child, yes, to trust, but also to feel inside of himself that he doesn't have to think about his needs being met. They are, and he can now go on to other things. He can look at the mobile, he can reach out for a toy eventually, he can crawl away from mother when he's ready to. All of that is because he's internalized a holding environment that is holding him in his existence and allowing him to go on. Somebody asking a question?
No, we're good so far.
No? Okay, good. All right. Does that answer the question, Archie?
Mhm.
Okay. All right. In fact,
Can we take a question?
sure, please.
Okay, Aaron, go ahead. I just want to say hi to Aaron Herzog and a special thank you for all the very prominent guests he's invited and recruited to join Mondays with Moshe. Thank you, Aaron.
Thank you, Moshe. I wish I would have brought out
Oh,
Mrs. Mark. So
hello, Aaron.
Aaron,
Yeah.
you got to put your mic closer to your mouth.
yes, hi. So here's my question. You mentioned that a schizophrenic needs to be taken care of as an infant, if I understood well.
No, I'm speaking only to, we're here talking about therapeutic connection and the healing process, the healing
Right.
power of the therapeutic connection.
So-
And what I'm saying is that a schizophrenic, we're talking about like an adult, okay? They yearn for connection, but have
Right.
no idea.
So how do we provide connection to a schizophrenic?
Oh,
You mentioned you called
okay, so that's a great question. Based on what I've said about the holding environment up till now, how would you start to answer that question?
So based what you said again, based
On the holding environment. Donald
Yes.
Winnicott talked about mother holding, creating a holding environment. That
I'm
is
trying.
not just holding the baby physically, right? But creating an entire environment in which what the infant from birth on experiences is that his needs will be met and he does not have to fear, he does not experience the anxiety that he will disintegrate or that he will starve or that he will be left to die. Okay, he is born into a mother who into an environment that holds him and provides him with whatever he needs. It's and is there for him to connect to. Right. Now, based on that, I actually want to elaborate on that as we go here. I mean, it's part of what I was going to speak about tonight. But having said that, Aaron, how would you answer this question? How would you begin to answer this question?
So based on my experience with schizophrenics clients, I would say that we should be for the client, just be for them, and the client will keep on testing you and pushing you away. And you should treat them. You should understand that he was used when he grew up to bite the hands of his feeder.
Or test the hands of his feeder.
Right. So we have to be with him, and the more it pushes us away, the more important it is not to be pushed away from him.
Exactly. You are providing him with the message. You're anticipating me a little bit, but you're providing him with the message. I am here. I endure. Your rage and your biting me do not harm me or damage me. I hold it. I hold you. and I am here for you. That's exactly right.
And how is
And
that different than
and the
treating?
question is, what is he experiencing when he feels that? There are two things that the schizophrenic will be experiencing. And one of those is incredible anxiety about whether he can trust it. Because maybe it's true in this moment, but who says it's going to be true in the next moment? That was never his experience. So you have to persist.
And doesn't that sound similar to the treatment of a borderline? I mean, everything sounds almost identical. Is it?
Well, the difference between a schizophrenic and a borderline is that a borderline has some hold on their ego is more developed. They have more, they're more reality based. But in the area of human connection,
Mhm.
they were left at a very very early state. Usually you find borderline personality disorder people, there was something that went terribly wrong in the maternal connection very early, mental illness, or a mother, who just totally couldn't care for children, or whatever it might have been. You're going to find that. So a father who wasn't much better, and that's they're not necessarily, they may have delusional ideas by it, but they're not hallucinating, and they're not. It's
Okay, but I'm talking about in terms of the treatment itself. It's the same holding environment that we're trying to create, right? It's the same challenges or similar challenges that they might throw at us by rejecting us, by testing us. What's
and
different
why
in the
is
treatment?
that? Because we're talking about developmental arrest
Correct.
at a very early stage for both of them, for both of these diagnoses. Right. Neither of them, by the way, have the capacity to simply experience themselves as safe enough to go on being. Something ruptures it. The borderline personality disorder patient will have all sorts of ways of self-interrupting or creating ruptures, or drawing you into an enactment where you did something horrible and you're just awful and you don't understand anything, and all in an attempt to repair these early ruptures. So the holding environment that we provide, which is our steadfastness, our being there, our being available, to the patient's needs, to the degree that the patient is not too terrified to trust that, okay, and to the degree that the patient can come ever so slowly to believe in that, is one of the most important things we can do for our ill patients and also our not so ill patients. That holding environment, that's going to be the foundation. Okay. Let's go on to the next phase of development. Okay, so the normal autistic phase is from birth to 1 month, and the reason we used it is because when the baby successfully reaches homeostasis, he can begin to relax and rely, and this is the cornerstone of basic trust. And if we're assuming normal development, the phase of development is the normal symbiotic phase from 1 to 5 months, that first half year of life. And what we find here is that once a baby is like 2 or 3 months old, I'm sure all of you notice this, we start to notice his personality. His personality starts to come out a little bit. We start seeing him as a special, as an independent being, just a little bit. By 2 or 3 months, he has his own agency. He can choose to look at something. He can choose to reach out for something. He's kind of social. He smiles. You smile at him, he smiles back. Okay? So we see that a 2 to 3 month old infant has a sense that he's a little bit separate from us, not like the younger infant. And we can see his separateness. And Daniel Stern, in his magisterial book, The Interpersonal World of the Infant, tells us that he's developed by now a core self. There is some core self there, and we can begin to see it. And is it around this time that a baby can experience, not verbalize, of course, but experience two-ness, you and me, okay? That's called from 1 month to 5 months, that period there is called the normal symbiotic phase. Now, what is symbiosis? Symbiosis means is 2 organisms that use each other to mutual benefit. That's what symbiosis is, and it implies a two-ness. Now, the baby, it implies a two-ness. The baby is certainly using the mother, getting his needs met. And I know Winnicott mentioned is some very interesting thing that babies internally experience, which is called object usage. They use the mother, and they're using the object. She's not like a whole person to her, with feelings and insides. Oh, he's 2 or 3 months old. No, okay. He uses her to get his needs met, to get himself gratified. He uses her, object usage, and so you have this duality: the baby using the mother, and the mother actually getting gratification from the baby. And how is that? Let me just mention before I get to that. The baby is not completely separate. As I said, I have separate insides, mother has separate insides. We're not up to that at all. In fact, the baby knows that the mother's an extension of him. Why? Because he cries, she comes. He's in control. Lo ela bishvili nivra ha'olam. And that happens to be very important, by the way. I mean, if we see this in someone older, we would say, oh, grandiosity. But this is very age appropriate for a 3 or 4 month old infant, that he feels that he's the core and the center of everything. That is the beginning of building up a sense of self, a core self. Daniel Stern's core self. That is very, very important. And Margaret Muller recognized that there's a duality in the way the baby experiences himself and the mother. She called this dual unity. Yes, I'm in control of everything that happens. And when I cry, when I need something, she's going to come. She's part of me. And yes, it is she and I am I. Okay. So you have, I've simplified it greatly. Okay. There is a sense that they're one, and there's also a sense for him that they are separate. Now, if developmental arrest occurs around this time, where all the baby experiences is that mother is there to gratify me and I'm there to use her for my needs and gratifications, what do we call that, folks? We call that narcissism. Narcissism is very difficult to treat, as Freud observed, for a number of reasons. One of the reasons is that there is in a narcissist no really clear sense that anybody else has insides that he has to take into account in his dealings with them. He's using them. They are there for him. They revolve around him. This is very similar to, this is one of the aspects of narcissism, one of them, is that it is a developmental arrest at this particular stage of development, right? Right. That's very, very important because, you know, you can't let a narcissist get you mad, or you can't allow yourself to feel wounded by them. This is where they are developmentally. And the developmental task for you is how do you make space and room to allow the narcissist to experience you as a person with your own insides. That's your goal. This is going to take work. Okay.
So wait, just before you continue with the treatment of the narcissist, can you elaborate for a moment or two on where the developmental trauma happened? In other words, what was going on that created that narcissistic need or sense? Was it the mother not being present? Was it the mother using the child? What's that process?
Well, I'm going to tell you, I'm going to answer your question in a very global kind of a way, Moshe. I believe that our work is, how do I put it? I believe that our work is deductive rather than inductive. It's deductive, meaning we are presented with symptoms. Until we explore this, we do not know what the underlying cause or the underlying deficit is. There are so many, you know, it's like you come in with a cough. What caused the cough? Well, I don't know. Maybe you have a cold. Maybe you have tuberculosis. Who knows? Mm-hmm. Until you explore, you don't know, in my view, what a symptom means. A narcissist is a person, perhaps, who was, there are many, many causes for this. Out of some sense of guilt, his mother overindulged him. He never learned to consider that other people have needs. He learned very early and was not corrected in this, that he can manipulate people to get what he wants, and people allow themselves to be manipulated. It is so vast. Until you know what it is, until you explore, we don't know the reason for symptoms. That's my position. Okay. That's what I found to be true. I don't know that can be answered. All I can say is that when you're dealing with a narcissist, the deficit in the narcissist is that he does not have room in his thinking to include that the feelings of others are important. Now, the question becomes, here's the question you can ask. We can ask those clinicians. How can we appeal to a narcissist's self-interest in order for him to discover that caring about someone else's feelings and someone else's needs will actually make him feel good? How do you accomplish that? That I believe to be the therapeutic task.
You're saying that the way to treat a narcissist is to utilize his own self-centeredness,
yes,
and to somehow induce a process in which it's selfish for him to help somebody else or to feel for somebody else.
Not selfish, but it will make him feel good, feel gratified, feel. Right.
Now I think there's an existential, famous existential question about this, with ordinary people who are not narcissists, which is, the famous question of, isn't everything we do, even if we're doing it for someone else, really on some level for ourselves? Because if we help somebody else, it makes us feel good. So how far are we from the narcissist? Once, if we can get the
Bishvilini for a whole lot, it's a Mishnah. Why not? The problem here is when that's all there is.
No, but I mean, if we can induce that process of the narcissist, are we tricking or manipulating the narcissist, or are we getting the narcissist to be more like us? Which is
I hear what you're saying. Here's how I look at it. I think we're being pragmatic. We're meeting the patient where he is.
Okay.
And we do that's
so you're saying it's irrelevant. As long as we get him to feel for others, then we've done our job.
Right. And the fact of the matter is, when he discovers inside of him that empathy is and feeling for other people actually might induce in him feelings he's never felt before, like tenderness for someone, or a vulnerability that he could never ever admit to himself, but he always knew was there. These are very moving moments in treatment, and they help him become a full person. And when he sees that the attitude of others changes to him, because narcissists are actually very lonely. I'm sure you've done.
Yes.
They're
very depressed.
lonely. And yes, they're very, and they don't want to be that. They don't want to feel lonely. So if they feel that people smile rather than edge away, they'll feel so much better. And they're actually recovering a lost part of themselves. Okay. So now, I'm very glad you stayed with that, because narcissism is so antithetical to the task, the work of therapeutic alliance, and it's such a challenge to it, and how to allow them to give them room and give them, well, to create space for them to discover that there might be a richer way for them to live. I'm glad we spent time on that. I really am. Okay. Now, inevitably, let's go back to the normal symbiotic phase. Inevitably, a mother will not respond immediately to a baby. She didn't hear him crying until he started getting hysterical, and then she heard it because she was downstairs loading the washing machine or something. But all sorts of ways, mothers are not robots; they're not perfect, and they don't respond right away. And the experience of a mother not responding right is very important for a baby, because that really is what tells him that they are two separate people. He cried, and because she has her own agency and didn't hear him, she did not respond that way. Now, what happens now this is very important, and we're going to see this in our practice. Melanie Klein has taught us that that when we're talking about infants whose emotions are very extreme and who split, right? Okay, when mother gratifies me, then she's good. And when she frustrates me, she's bad. Okay, what's really important about this, by the way, is that everything is tied up everything that a baby feels is tied up with connection and with connection to the mother. That's very important. It's a very important part of the interpersonal field that we work with also. So also there's something very interesting that Melanie Klein spoke about, and this is usually people stop being able to understand her work, but it's very, very important. Babies have an intrinsic understanding of the breast. They know it exists. In 3 days, you ever see an infant? You stroke his cheek, it goes, okay, yeah, right? Okay, all mammals do. If you ever saw, I saw once.
You spoke about the sheep.
sheep.
Last time you spoke about the sheep.
Yeah, last time, right?
As soon as
on
they're
their
born.
knees, they can't walk on their knees. They make their way to the teat. Right, that's right. Everyone is born. All babies have a formulation of the breast. So there's the breast, and the good breast gratifies, and the bad breast frustrates. Now, why is this important, this idea of the breast? What does this mean? It means that babies see their mothers as part objects. They don't see them as people as a whole. They see them as that which gratifies. And I said last time also that an infant, 2 or 3 months old, okay, doesn't have a concept of his mother as a whole. He's in the present, every moment is separate and distinct. He does not yet have the neurological capacity, the mental capacity to understand past, present, and future. So right now, she's the feeding mother. And right next moment, she's the changing mother. And an hour later, she's the soothing mother. But he does not yet have the capacity to put together that she is this whole person doing separate from him and doing things for him. This is how he experiences mother, as a part in parts. The breast, the part of her that feeds, the part of her that changes. If you take, I think I mentioned this last time. If a mother hands her 3-month-old infant to somebody else, you know what that infant's going to do? He's going to go start looking up at that other person's face and study his face. And if that person hands to a sibling or somebody, then he's going to now start looking at that sibling's face. That's what he's going to do, right? Each moment is separate. Each experience is separate. He doesn't start putting his experiences together until much later. A baby, 2 or 3 months old, does not experience separation anxiety because he does not have enough of a picture of his mother as a whole, separate from him, developed enough to be able to realize that when she goes away, he should be anxious. He doesn't have that concept. Okay, so
So can I just ask real quickly?
yeah.
You talk about the frustration, a frustrating breast. If you have a baby whose mother is struggling, let's say with lactation, and
Okay.
is not producing enough milk, and the baby is trying to nurse for a few weeks or a month or so until the mother, it's a young mother, she doesn't really know much about nursing, and no matter how much she tries to nurse, the baby's not getting enough milk. Will that create trauma because of the a full 4 weeks of frustration immediately postpartum?
Well, babies' nervous systems, their neurological function is extremely plastic. It really is. I would suggest to you that at some point she's going to want to feed her infant, is going to have to throw in the towel and start giving him bottles. And I'm glad you brought this up, Marcy. If she holds the baby and bottle feeds the baby and coos to the baby and talks to the baby and he feels her presence as she feeds, that's good enough. Right.
Okay, but my question was more if the baby's not getting enough milk during that time until the mother realizes that's something that she needs to supplement, will that potentially risk trauma to the baby?
No, I think I won't say no. I think it would depend on the infant. I won't say, absolutely not. I will say this. that I'll tell you, I had a grandchild. We don't know what happened, but this particular grandchild was extremely anxious around anybody holding her who was not her mother for the first year and a half of life. We don't know why. We don't know. We don't. She's now 8 years old and the most engaging kid you could imagine. But at the time, something must have happened to cause this to happen, to cause this to be. We don't know. I will tell you, though, that if a mother, babies can have bad beginnings. They can. This can be one kind of a bad beginning. They could have needed emergency surgery the minute they were born. That's another kind of bad beginning. They can, but with ongoing good enough mothering, the holding environment, the consistent care, babies do heal from this. Okay. I would like to say that yes. Now, I want to talk to another very important point. We call this the normal symbiotic phase, and we know. I might have mentioned this last time, Moshe. I don't know. I think I did, but well, it's good to go over it. We know that symbiotic means that two organisms feed off each other to mutual advantage, right? What is the mother getting from the baby? The mother is getting her pleasure in him, her nachas from him. That is what she's getting. Now, we're not here to talk about mothers. We're here to talk about infants. When an infant interjects his mother's nachas in him and his mother's love for him, he starts to build inside of himself a self-concept that he is loved and lovable. Right. Now, here's where we get to really the crux. And what is the parallel for maternal love in the therapeutic relationship? It's empathy. Empathy and attunement, being aware of our patient's needs, and them eventually coming to realize that we do want to understand them, that maybe we got it wrong, maybe we did, but tell me, help me understand, because I genuinely do want to understand. And over time, our attunement and getting it right much of the time, and our empathy are what will enable a child, an adult, to move on and heal. This is what helps develop a sense of self. I am lovable. Someone has empathy for me. My needs mean something. Someone wants to be attuned to me. When the patient over time interjects this will build up that sense of being loved and lovable, and I can be understood. That is a major achievement for many of our patients.
So you're describing this as would you say this is the primary curative factor in psychotherapy?
I am saying that the holding environment plus the attunement and the empathy that we show our patients week in and week out over time are going to be the foundation from which he can emerge, from which he can share himself and feel safe sharing. He can begin to put things into words. We can help him understand meanings. That's our nourishment as mothers, and he can begin to heal. But the foundation is going to be the holding and bearing, the maternal love, which is empathy and attunement.
So in other words, I use the term a re-experiencing of the self. what we're creating for the patient or the client is a re-experiencing of what the self, what his or her self is. Till now, it was a self that was unlovable, that may have had to withdraw and hide, or may have had to be, on the contrary, aggressive in order to survive. These defense mechanisms that they developed over time in order to survive, because of these deep wounded senses of self, are now being re-experienced as a self that's lovable, that's delightful, that's interesting, that's important, that's valuable. And that re-experiencing of the self will, number one, cause a tremendous amount of change. So we'll see clients behaving differently towards us. We'll see them calmer. We'll see them more open. Emerged is the word you used.
Mhm.
And then from there, we can start doing things that include understanding the self, introspection. Why do you behave the way you do? Understanding the defense mechanisms. Is that right?
Yes, I think that's right. I like the idea of the re-experiencing concept. I like that very much, because I think of it in similar ways. I think of it as recovering lost parts of the self that the patient always knew was there.
But how did the patient know
There
it was
is
there?
always that, what?
How did the patient know it's there if the mother never provided that, or if the mother never provided it?
Because when they recover it, it is at that moment that they knew it was all along, but they had no words. That is how I see my patients. That's what I've experienced in my own treatment, and that's what I've seen in my patients. Realizing on some level, even if they don't communicate it to you, I always knew this was there. I always knew this was me. It just could never come out. Or
I wonder if there's an inherent, evolutionary or natural sense that a person who's born has, that there must be some meaning or purpose to them. And that's what, this is more of an existential approach or perspective, that a person inherently can't exist without feeling or knowing that there must be some value or purpose to them. And their sort of goal in life, again, this isn't a conscious process, but what they're looking for and calling for, as Frankel would say, is to find that. And when it's finally found, even if it was never experienced before, it's an aha. This must be me. Who is my mother? Who am I? This must be me. There's something natural that connects with them. But that's my own thought.
Okay. It's interesting. It's interesting.
I think that's what the existential people would feel, would agree to. Okay. I want to welcome Efrat for coming on here for the first time. Welcome, Efrat, and I'd like to take a question from her. So go ahead.
I was just wondering, within the symbiotic relationship of the mother and infant, so there's just like this natural feeling that this is right, and the mother is receiving pleasure from giving to the infant because this is good, this is right.
What do you mean? Please help me understand. What do you mean when you say this is right, this is good, this is right? What do you mean by that?
This is healthy. This form of giving, I'm giving to my baby in a way that will nurture her and will make her, like what we were saying before, develop as a self, right?
Well, through getting the infant, through getting their needs met, through that process, getting their needs met from an other, that enables them to experience themselves.
Right.
Do you understand what I mean by that?
Yeah.
Yeah.
So I'm making a parallel over here because before we were talking about narcissism, and I find that one of the obstacles I have with narcissistic clients are that as a mother, for example, the mother to the infant, the mother feels that this is right, this is good, this is healthy, because she's providing something that's the fundamental. But providing the same need for a narcissist, it feels so wrong. And it feels like I'm enabling. It feels like, so my question is, how do we replace, if one of the ingredients of the mother to the infant, if one of the ingredients of the symbiotic relationship is that pleasure of giving to the baby, I can't feel that pleasure when I'm feeding into a narcissistic need. So how do I fulfill their needs when I don't feel it's right?
Okay. Let me see if I can understand you. Are we talking about the mother and the infant, or are we talking about the therapist and the patient? What are we talking about here?
Right, I'm talking about therapists to patient, and I'm using the mother-infant relationship to make the to contrast.
That's what I wanted to be sure of. Okay.
Yeah.
All right. The question that you need to ask of a narcissistic patient, you as a clinician have to ask, what does this person before me that I have a mission to help, to do my best to help get them, make them better, what do they need, as opposed to what do they say they need to gratify their narcissistic, whatever it may be. Is what the patient says they need what they need? Or do I determine as a clinician that if what they need is simply going to be enabling their illness, that is not what they need at all? They need something different. I won't verbalize it that way, the question, but I as a clinician now have a challenge before me. The patient claims that they need to be able to call me whenever they want. They need it because otherwise they're going to fall apart, right? I know that this adult does feel very anxious until our next session, I know, but I've also assessed that they can tolerate, they are able to tolerate that anxiety, and we will work it through the next time. And that my letting them have carte blanche is in fact causing them to stay the regressed, needy, demanding infant that they were, because they were not getting what they needed appropriately from their mother. They are simply drawing me into a reenactment, and that is not in the patient's best interest.
Right, but what if, especially with the narcissistic population, most of what they think they need is not what they need. I mean, I have
Correct.
a hard time finding even one incident where I feel that what they want is what I should be giving to them. But part of the treatment is to kind of give in and be able to because let's say they're not there yet. So let's say they're only able to see 1% of me, 1% of someone else outside of them. And the other 99%, I'm giving into them, giving into their needs, because that's the minimum that they need right now.
Are you able to give a specific example so I feel like would be more helpful that way?
Let's say the client comes in and she's rambling about how everyone's mistreating her and all the wrongs that people are doing to her and how she's being taken advantage of, etc. Now, let's say let's say she asks me a question and I try to respond.
What question, for example?
what do you think? Do you think that person was right?
Mm.
So let's say I start to respond and she cuts me off, going back to her tirade. So so here is where, for example, I would say, I'm feeling a little bit, ignored or cut off because I really wanted to answer your question, but I didn't feel that basically I would bring myself into the picture a little bit, to see if she could stretch her, window a little bit to see someone else. So I'm calling that, for example, the 1% where I'm trying to get her to experience someone else.
Why do you feel she cut you off?
I think that she didn't want an answer to begin with. It was like a rhetorical question.
Okay.
She wanted validation.
Okay. So okay.
So now for that's an example of one attempt of what I would do. I can't do a 45-minute session with constantly doing this because she won't come back to therapy. Right now she's in that place where she needs me to not agree, but she needs me to listen and validate and do all of that for her. I'm fulfilling that need, but not feeling good about it at all, so that's why I'm bringing this contrast to the mother and the infant. The mother feels so good because you're giving to the baby and it feels healthy, it feels right. But when you're giving in these needs that this narcissistic person actually needs, because they can't go any further right now, but it feels so wrong.
I got you now.
So where's the symbiosis? That's what I'm asking.
Okay, very good. I hear what you're saying. I don't know if what I'm going to say is going to be the on the mark, no pun intended, for you. But I'd like to try. When you find a patient talking about everybody else and how victimized they are, it's a defense against what's going on underneath, or what's going on. I'm not that arrogant, really. I don't know, but I can say that something to explore about what's going on is that you're dealing with a person whose ego is very fragile. Their sense of self and their sense of their own, they're very fragile. They dare not, it's very threatening to even approach the possibility that the things that are happening to them are really self-inflicted, or that there's something in this material that they really need to understand about themselves. They're really not able to do that. They're far too fragile to do that. Now, having said that, I would suggest to you that your patient has drawn you very subtly into a reenactment. You don't feel any sympathy for her. You're really very irritated by her. You're frustrated by her. You can't get in. And you are now her mother. Everyone is like that. No one has patience for her. Okay, this is what happens. So what happened here is your countertransference experienced her the way everyone in her life experienced her. And that's giving you a great deal of information about her. She is so fragile. So when you have someone like that, full of fire and dynamite, throwing it here, and blaming everybody else, full of that, And underneath, you know that they're very fragile. What would your approach be now?
It definitely helps me be more compassionate, but I still.
And when did this woman ever experience compassion from anyone?
Right. But I still feel that I'm enabling it.
That you're what?
I still feel that I'm enabling it. I don't feel good about validating and being there for her.
Oh, I don't know that you should validate it, because you know, one of the things I've noticed is that she's talking about everybody but herself. How can you make it safe for her to feel that that there's room for the two of you gently together to look at where, you're not here yet, but you're creating the ground to look to see whether she has some hand in this. You're not there yet, not for a long while, but
Right.
how would you prepare a very receptive, compassionate, holding environment for her to be able to look at her own shortcomings, or
Right.
look at how she fails.
Right. So by me providing what she needs right now, even though it doesn't feel right, it's
No.
to create
What she needs right now is for you to say something like, it sounds to me as if something along the lines of, it sounds to me as if you're hurt, right, left, and center. Right? Well, you feel hurt all the time. No one comes along without you feeling hurt by them. It's her feelings, it's her perception. It's not you're right, you're right. This is how you're experiencing it. Everyone is hurting you.
Right. So even if I don't feel good doing that, I keep in mind.
Oh, wait. It's important. It's important for you to realize that's her experience, and to get her at some point to realize that there's a difference between perception and reality. That's where you're going with this.
Right.
Okay. This will take you work and time, but for her to begin to realize that months from now, maybe, that there's a difference between perception and reality, that would be a real opening for you.
Yeah.
And it would give you room to work also.
Right.
Mm-hmm.
Thank you.
Mm-hmm.
Well, that was amazing. Thank you for that. Thank you for the question. And I think it gives us a great insight into what it is that this individual needs, and how Efrat herself as the working therapist has to sort of refocus her experience of the client to be able to position herself to nurture the client.
You know, I would say that that's true. I would also say, Efrat, that you wouldn't be asking the question if you didn't feel that that's exactly what you wanted to do. You do want to. It's not that, I don't think it's so much a matter of your feeling you're enabling her. I think it was much more a matter of you're asking yourself, what can I do for this client that will give me the room I need to be able to help her? It's, yeah.
Right. And also specifically, like when you were speaking about the pleasure that the mother gets, the delight of giving to the baby, that really contrasted to me my experience with my client, which is the opposite of delight, but giving her what she needs. That's why I thought of that.
Yes, I saw that. And I think that your instincts were very good in realizing that she's trying to extract something from you that you realize would not be in her best interests to give her.
I want to just add one piece to this. I'm wondering if, effort for you in the broader scheme of this client, you can't, like you pointed out very, very intuitively, that you wouldn't be able to call the client out on every misnomer or misdemeanor that they do in their communication with you. You kind of got to let many of them go and store that information. You want to store that, hold that information, so that when you sort of build up a case or build up a hypothesis as to how this client interacts with society, how they work interpersonally, right? You're developing a hypothesis as you watch their interactions, and then sporadically, every once in a while, you can bring that out conceptually, right? I noticed that I noticed that the way I noticed that you seem to, right? So if you take the opportunity to make these observations and hold them, and then use appropriate timing. I know last week with Nelson Solomon we spoke about timing. Use the appropriate timing to bring that out, to reflect when they may be in a moment of vulnerability or in a moment of reflection, or rather than you doing it impulsively when you're not feeling good towards them. Even when you said earlier, that you call the client out on it right away. I'm feeling, I wonder if it would be more effective if you'd wait for when you're not feeling it so strongly, and then say, sometimes I notice that, or sometimes I feel that.
Right.
Right. So you want to kind of take these little bits and pieces and take them as bits and pieces of evidence and information, store them in your mind, so that rather than becoming or feeling triggered or allowing your trigger, to guide you, you can then build up a case. And then once you have a hypothesis, share that with the client in a very gentle way later on.
Right. And once you get into the rhythm of being mindful and observing all these things, and you can actually like take delight in the client and like actually be happy with what you're doing.
Right. And appreciate the process, appreciate what they're struggling with, appreciate their story, their process. Now I can see them as a struggling person rather than as a manipulative person.
Mm-hmm.
Yeah.
Mm-hmm.
Okay. Any other questions? I thought this was very beautiful. Chana, where are you holding? Did you have more to share on this?
On this particular note, let me see. Let me take a look at where I was and where I was going, and maybe it would be useful for others and for Efrat as well. Right. My mind is going back to what Efrat was saying, her awareness that what the client seems to be demanding from her is different from what the client patient actually needs. And I think this is very, very important. We talked about attunement. When you hear a patient feeling so bruised and so wounded, and by the way, do you just a quick question, Efrat, just a quick question. How long have you been seeing this woman? How long have you been seeing her?
7 months.
7 months. Okay. Do you have a sense that she's a person that operates from the position of grievance, victimhood? She's jealous of people. Do you get that sense of her?
A touch of paranoia, a lot of victimhood, grievances, yeah. Really very, very paranoid and irrational.
Okay, well, right. Okay. So I am hearing acute anxiety. Do you, especially when you said paranoia, the other place I would say,
Yeah,
right?
definitely. Yeah.
Yes. See, I think this, and this might take you a while to get through also, that this wall she puts up of grievances and talking about other people and all of this is a way of keeping you at a distance, of distancing you, because she's terrified. She's very anxious about letting you in to see her true self. It really goes back to this fragility in her. I would say that you think she wants you to see things her way. You could certainly say that something like along the lines that, like what we said before, I think is very good. Like you seem to be, very unhappy with the people around you. And it seems that you don't feel very close to the people around you. To introduce these ideas for no other reason, just to introduce the idea of being close, to introduce them, to introduce something like food for thought that you're introducing into the field. And you just see how she responds to that.
Right. I mean, she can also get very defensive at that.
How so? Remember, when you're looking at defensive, you're looking at anxiety. What is the anxiety behind the defensiveness? You're asking yourself, what is she so anxious about? What is causing this anxiety?
Okay.
What is this about? You could even ask her, I'm getting a sense that you're very anxious. Are you feeling anxious? She'll say yes, no, but you've introduced it into the field.
Right. Planted the seeds.
Okay. Folks, it's getting late. It's 10:25 here in New Jersey. I think we're going to call it a night. Chana, that was very, very enlightening. I really appreciate it. I connected and resonated very much with the feeling that I have with clients in the room, and the change that happens that's sometimes so subtle that you only notice it when you compare your memories of the clients from months or years before to where they stand today, and you can start to sense and feel how they're different, how their self is different, not just how their symptoms are different or what they're reporting, differently in their anger management or whatnot, but you can kind of feel a different person, and which lends itself to a different beautiful process, which is the process of exploring and reflecting. Sometimes I'll say to a client, can you remember how you were a year ago, where I'd ask you a question, you'd hardly hear me. Sometimes you wouldn't even, it would feel to me that you don't even notice I'm in the room. You're kind of so absorbed in yourself. You didn't notice there was another person here. You took up so much space in the room. And now I actually feel like there's two people in the room. That's how it feels. Do you notice that change in you? And then we can explore that itself. So these are the deeper processes that occur in the change that goes on in the psychotherapeutic process.
Mhm.
Okay. So can we call it any final closing thoughts or words before we end, and then let's see if we can.
Yeah, only that I'm very happy that we got this far, but I have another several pages to go. So
Good.
next
So,
time you want to
part 3.
schedule me, we'll discuss it, and we'll continue from where we've left off.
Okay. Yeah. Well, Mr. Shem, we'll bring on part 3 sooner or later. Let's look at all the exciting guests who we have
Yes.
on the table and set them in the calendar, and then let's see where we go from there. Okay.
Wonderful.